That'd be fine.
Yeah,
Well,
just
press
press
play.
play.
Okay.
Well, I'm
sorry.
It would have been okay, but.
Facing forward and just enough to feel where they clear. We go from here. It's just a small amount. You're probably okay. I think we were okay. I don't think she was too much. It's just a small amount. Not too much?
No, it was too much.
Okay. Okay. Barely feel the difference in them coming off of each other. It's barely a rotation. 15 to 20 degrees is barely.
Okay.
Just facing forward, and then just, then ultimately you'll line it up with that line too.
Not too much.
Mm-hmm.
Okay. Okay, so like just so this hand is a little further.
Correct.
Okay. That makes sense.
It's really tiny.
Yeah. I'm like, you just barely, yeah.
I don't know if that's long.
And she's so we do. You're already right there?
No, I'm here right now.
Okay.
Okay, that's all? Just enough to clear it. Okay? And once you have your patient positioned, your breathing instructions are to just breathe normally. Okay? We want to use a long exposure time. That's for a breathing technique. It needs to be at least 2 seconds in length, so she has plenty of time to breathe so that the chest moves. You want the chest to move to blur out the ribs. Okay? And that movement is considered autotomography, like self-tomography. She's breathing it, so by herself she is blurring out those ribs. Okay? So that's the RAO. From the RAO, we're going to do the lateral. We're going to back up to 72 inches. Okay. Still using the 10 by 12 lengthwise. I have to recollimate because I'm at 72 inches now. And this time, though, I'm going to go the full 12, but I'm going to come into about 5 inches wide. Because once you go lateral, the sternum's, not even a half an inch thick, so it's not going to take much there, okay? And sometimes what will happen in this room is once you'll end up having to realign it a little bit just because of the distance thing. It's a physics thing with the light, but all right. So I have my patient step up, turning the apron for the lateral, okay, and having her step up. Now, depending on how much curve somebody has to their chest, because some people will be very straight through the chest part and some people will come out more, you may want to turn the tube head a little bit. I like to keep it turned a little bit because then I can center better and keep my collimation tighter. Because if you don't and they come out a lot, then you have to open up wide to make sure you get the top and the bottom of it. Which makes sense, right? If you don't turn your tube head. Okay. Now what I want to see here is for my light to skim off the front of her chest. My crosshairs are here. I want to see part of it on the board and part of it on her. See how I can see most of it on her right now? So it's really not positioned where I want it to be. I'm going to back her up just a hair. So now it's about half and half and it's skimming off the front. And the last thing I need her to do is to bring her arms behind her back so that I'm pulling the shoulders out of the way. Okay? And then you can double check that. And sometimes that'll move the patient a little bit. You just have to kind of double check, but it'll get you in the ballpark of where you want to be. And then just place your marker anywhere in the light field here anteriorly. And so I should have xiphoid and I have manubrium notch. Okay. Now for this one, I'm going to have her taking a deep breath and hold it. You want deep inspiration. It's going to fill the lungs with air, which is going to be very dark against that bone of the sternum. This is a really ugly film though. All the time it looks really gray. It just is because the sternum's not very big. But putting that air behind it does help give you some contrast so it looks a little bit better. So deep inspiration for this one. Okay? And then that 72 inches is helping us with the magnification because we have this distance here.
Okay.
All right? So our patient can relax. So that's the sternum. RAO, 15 to 20 degrees of rotation at 40 inches, breathing technique. Then back up to 72 for the lateral. Okay? Now, from this, we're going to go ahead and do the ribs. All right? because we want to do our ribs at 72 inches. We'll swap out the 10 by 12 or 14 by 17. Think of this like you would a chest x-ray. Okay, other than if everybody at clinic does them crosswise, don't do that. You only want to do them crosswise if body habitus really warrants doing it crosswise. So we'll do everybody in here lengthwise. Okay. We want to assume that we're trying to do bilateral ribs, which means we want to get right and left side on here. Depending on your protocols at your institutions, they may always be bilateral, or they may be unilateral, where if the pain was just on one side, you could collimate and just do that one side. But we want to assume bilateral here, okay? So I've got my 14 by 17 lengthwise. I'm going to take my full collimation. Okay. And then what we'll have to tell you next week after you do your sternum is we'll have to tell you where your patient's pain is. So we'll tell you that either the pain is anterior or posterior. If it's anterior, then you would put the anterior surface against your image receptor. So you shoot everything PA. If it's posterior, then you're going to put the posterior surface against the image receptor and shoot AP. Okay? So I'm just going to say that hers is posterior. So I'm going to bring her up here and make sure you shift the apron around to the front again and shoot an AP above the diaphragm ribs. And pretty much this is just like doing a chest. Okay? I could turn her around and go to the inferior angle and find the inferior angle and center at that point. I can keep her AP and then adjust the height based upon, it's pretty close, having about an inch to an inch and a half of, cassette above her shoulder. All right. And then placing my marker, I know we get really hung up on kind of making our markers look like this, but if we go long in here, we could end up in the ribs. So it's okay to turn it sideways. You can turn them diagonally. I mean, as long as you're showing the letter, right, or the L, and your initials, the position you have it on, it doesn't matter, okay? But you would keep it out of the anatomy, okay? We did discuss in the last lab, I didn't do it yesterday though, that some people, if you have room to do this, you can actually have your patient point to the one place where their pain is, and you can place your marker at that level, okay? And so, then you could say, you could annotate the pain is at the level of marker. Or some places will use BBs and stick BBs on the patient. Or use a nipple marker, but place it to wherever they point and say their pain is so that you identify for the physician, for the radiologist, where to look. Okay, I mean, you should be looking at all of them, but it's always nice when you can say, look right here.
So instead of shooting all 4 of the rib projections, we're just going to do whichever one you tell us to?
Correct. We will tell you if it's anterior or posterior, and I'm going to show you both obliques, but we're only going to have you do one, and I'll get to that when I get to the obliques and explain more about that. So we're assuming her pain is posterior, so I'm going to shoot an AP. All right. I've got a collimation, I've got my marker here. I'm going to ask her just to bring her arms out away from her body a little bit. It doesn't have to be a big, huge motion because the arms get very heavy, but enough so you don't get shadow of the arms in with your ribs. Okay. And because we're doing above the diaphragm ribs, I should be mid-sagittal plane. We are. Mid-sagittal plane. I'm going to have her taking a deep breath and hold it. She breathes in, diaphragm goes down, nice air-filled lungs to give you contrast behind the ribs. Okay? So deep breath in and hold it, and that would be our AP above the diaphragm for posterior pain. If it was anterior, we'd have done PA the same way. And you only have to breathe them once. You don't have to breathe them twice like you do for chest. And we're really, although as part of rib series you would have done a chest already. Yeah. So, okay, for this we had, after you shoot the AP or PA, because we told you anterior or posterior pain, then we're going to tell you that the pain is either on the right or the left. Okay? And depending upon which side we tell you, we want you to elongate that side. Because what happens when you shoot the obliques is, depending on which way you rotate them, it'll either elongate the side, which shows you the axillary portion, or it foreshortens that side, and it'll show you the attachment to the spine. So, but most of the time, if the protocol at a hospital only includes one oblique, it'll be the oblique that elongates. If it's both obliques, then you do the one that elongates and the one that foreshortens. You'll see people turn people around, do one AP, one PA. No. Whatever you started with, that's how you should shoot your obliques, because you should have your pain closer to the image receptor. Okay. So I'm going to assume, since I have a left marker, that it's her left side. Okay, so I'm going to do an LPO to elongate the left side. If you look at like the chest as being like this, like here's on my little ribs, okay? So here I am, and I'm trying to elongate the left side. If I go LPO, this one curves up and this one opens. And so now these are elongated, and these would be foreshortened. That makes sense? And if I went the other way, then the right would be elongated, and the left would be foreshortened.
Okay.
But in a true rib series, you would do both because you want to see elongation to show axillary and foreshortening to show attachment to the spine. Because they both do show something different. Okay, so I'm going to have her now turn away from me because I'm going to do the LPO. How much do I want to rotate her? 45 degrees. Yes, here's where your 45 comes in. And if you have a hard time with it, seeing it, almost every hospital has tile floors. And if the toes are pointing kind of towards the corner, I mean, based upon how they're laid, obviously you can't be right to the corner, but that'll give you a good idea of where 45 degrees is, okay? And have your patient move their arms out away from the body. And you can do all this fancy stuff like this if you really want to, but it's not necessary if you want them to strike a pose. There is not a single place where I'm going to put my crosshairs, okay? What's going to happen is I'm going to appear to be centered to the opposite side of what I'm interested in. But what I've got to make sure is, do I have all the left side and do I have all the right side if they will fit? If they don't fit, then you got to be sure you get the side of interest, and then you would have to shoot another one and shift them over if they didn't fit. But I can see I have a lot here, so I'm gonna have her step away from me. Maybe 10. So I want to be 45 degrees. I want to say light anteriorly, and I want to see light posteriorly. Now I know I'm centered up okay. And you can see that it appears I'm centered to the right side, but I'm getting both sides, but I'm elongating the left, okay? And so that's what I want, and this is, the arms have to come out or else that arm is all up in your rib, and you're not gonna see anything, okay? And we're still above the diaphragm, so I would deep breath in and hold it. Okay? So if I have posterior pain, then when I oblique my patient, the side closest to the image receptor is going to be elongated.
And it's just the opposite for
PA, correct. All right, so y'all would do that, and then if I was doing the full series, then I would just reverse her position just so y'all can see it from here. And if you had to, you could shift your apron. Well, I'm not going to shift it, but you would shift the apron. So we look for the 45 degrees here again, and then I've got to make sure I have light here, posteriorly, and light anteriorly. Okay, and the arms out of the way, and again, she would take in a breath and hold it. Now I have foreshortened to the left side, and I can see the attachments to the spine. Okay.
So on one side you elongate it, and on which side the side you're elongating, the other side is shorter, and then it's opposite when you do it.
When you turn it the other way, yes.
Okay.
I mean, here's what's happening: elongate, foreshorten, elongate, foreshorten.
I get it now.
Now, if I was PA like this, you have to think about it. I'm going to let's put her up here, PA, just real quick. So if I was PA and I was still interested in elongating her left side, now let's say she has left pain, but it's anterior now.
You did it on the right.
Okay, so now instead of it being closer to the image receptor, it's going to be the side farther from the image receptor. Because if I'm doing this, you see what happens if I start here, this opens up and this one closes.
Okay.
Does that make sense? Okay. And then it will be the same.
You're doing that day, it's because I'm going to do that.
We'll do that. It might help.
Yeah, that really did help.
Okay. All right. So she can relax. So what will happen is when we get ready to do the ribs, we'll tell you anterior, posterior pain. You'll do AP or PA. Then when we come back in, we'll tell you right or left side, and you will do the oblique that is appropriate for that. The pain is still either anterior or posterior, like we told you, and you will do the oblique that elongates the side of interest. Okay. Then the last image that you'll take is a below the diaphragm image. Now the below the diaphragm, regardless of where their pain is going to be done AP, because below the diaphragm ribs are done to show 11 and 12, and ribs 11 and 12 don't come to the front, do they? No, so we're going to keep them close to the image receptor for both. And because they are lower and they're really more like shooting abdomen, we're going to come back into 40, and you would use like an abdomen technique to shoot below the rib, below the diaphragm ribs. If we left it at 72 and had to use that kind of exposure factors, it would be huge at 72. So we want to bring it into 40 so we can keep our mass lower, so our patient exposure is lower. We're going to use the 14 by 17, but I'm going to turn it crosswise. And I am going to collimate, okay? I'm going to collimate down a little bit. It's 14 by 17 crosswise, but I'm going to use 11 by 14. Okay, because we really don't need that 17 inches wide, especially when 11 and 12 don't even come, out very far. When you mark this, mark it at the bottom, because even though 11 and 12 are short, sometimes you can get a better look at 9 and 10 from this than you can, because they end up being a little light on your above the diaphragm ribs, so this can give you some useful information. So if you mark it at the bottom, you don't have your marker in the middle of something that could be useful to you, because you get nothing useful at the bottom. You're in the crest. You're close to the crest by then. Okay. So I have her step back up here and face forward. I'm going to center halfway between xiphoid and umbilicus. So I'm going to find xiphoid and umbilicus and go halfway in between. That usually puts the the bottom of your light field at the top of the crest, roughly. That could vary from person to person, but it's going to put you kind of in the ballpark. Let her lean forward a little bit so I can read the line. And because it's below the diaphragm, I want the diaphragm to come up, so I'm going to have her taking a breath, blow it out, and hold it out. We're going to shoot this on expiration, so the diaphragm comes up, and then you get uniform density that looks more like the abdomen to see 11 and 12. The arms do come out away from the body a little bit. Again, that it's because we're looking at 11, 12, not as critical, but yeah, just move the arms out of the way all the time. It's going to be your best option is to keep the arms out of the way. Doesn't have to be a huge flapping motion, but enough that it's away from the body. So, what you will do next week is RAO sternum 15 to 20 degrees of rotation at 40 inches. Lateral sternum at 72. Then you'll do the AP or PA above the diaphragm ribs at 72. Then whichever oblique elongates. And then you'll come back into 40 to do the below the diaphragm AP.
In other words, we're going to be playing with this all day.
Well, not all day. You start at 40
And you end at 40.
40. 40, 72, 72, 72, 40.
Well, that's good. Y'all are out here next week, aren't you?
And so we just got the room fixed, so the digital room is up and running again. And he said he removed the part that was causing the trouble. We should never have this problem again. And he did put asterisk. Then he said asterisk after he said never have it again. Asterisk. So we won't do any anatomy and we won't shoot an image. And remember that y'all have that test, and as people finish, I'll tell you because you usually the first one's done. As people finish, then come down and find me as people finish, and we'll get started on checking everybody off.
So it doesn't matter if your partner's down here, you just pick a partner and that's how you do it?
No. Well, you could if you wanted to.
Oh, okay.
But I'd hate for your partner to be left in the lurch if they can't find somebody later. You know what I'm saying?
Oh, okay.
So, but I know y'all are, if you talk to your partner now and you want to talk about that, just make sure you have, I don't personally don't have a problem with it, but just make sure your partner's not like all of a sudden left in the lurch and they have nobody to be their patient.
Well, and plus you need to choose somebody who's be in whatever room you're supposed to be in. And we're trusting y'all to keep, honest on that and not.
Okay, gotcha.
Y'all work that out.